Well, good afternoon, everybody. It's 12 o'clock sharp, and it is our pleasure to welcome you to your next departmental lecture, which will be presented by Moses Mokaya. And I think he will have a very nice example of a true public health research topic. So we are very much looking forward to hear your experiences and the work you've done so far during your PhD.
Thank you very much, Prof. I appreciate. If it's fine, I can proceed. I see quite a number of people are joining now.
Yes, please go ahead, because people are probably having lunch while listening to your story. Here's
Yeah,
yours.
that's fine. That's
Yeah.
pretty fine. Thank you very much, and welcome everyone. Thank you, everybody. My name is Moses Mokaya. For those that are just joining in, I come from Kenya, a country that is commonly we pride ourselves with for long distance athletics, and of course breaking many world records, including the spectacular landing of the Kenya Airways plane in Heathrow against the Eunice storm. So my presentation today is entitled "Things Are Different on the Ground." Experiences in designing, planning, and implementing studies in low-income countries. First of all, something became different as I shared this slide, because what you see, the title over the picture is what I did not expect, but we've learned to work with what happens actually on the ground. A little background to the picture on the first slide. Kenya is getting into an electioneering period in which elected leaders go back to the areas where they're elected from to seek for re-election or to seek for fresh mandates in representing the people. But unfortunately, because the national parliament sits in Nairobi, many of them forget to go back to the people that elected them to get views and to reconnect with those people. So when they go back again, they find that the ground has changed. So in Kenya, we say vitu vimebadilika kwenye ground, meaning that things have changed on the ground, and that is the title of my presentation. But here I'm going to give a presentation basically looking at my experience during my PhD work, collecting data and implementing studies in Kenya. So this shall be the scope of our work today. I look at the background and a little bit of the scope, then experiences from 3 studies. Then I'll also relate the experiences with the application in design and implementation of public health interventions. So once again, the way I had structured this, they were supposed to come in different times, but now I have to deal with it as it is now. First of all, type 2 diabetes is a problem, a public health problem that is affecting many parts of the world, but in low and middle income countries, the prevalence is higher, and it is projected to rise much higher than any other part of the world. And the issues that are associated with poor management of type 2 diabetes in low and middle income countries are weak health systems, lack of health insurance, poor income levels, socio-cultural factors, and other incidental factors like COVID-19 that happened recently. But evidence has shown that to optimize diabetes care in low and middle income countries, collaboration, resource optimization, standardization of care, behavior change, and technological innovation can play a big role in improving the care and, of course, the treatment outcomes for people living with type 2 diabetes in low and middle income countries. And therefore, the scope the aim of my PhD work is to optimize glycemic control in adults with type 2 diabetes in Kenya. But for today's presentation, I shall share the experience in 3 parts of my study. A qualitative study where we sought to determine or explore the perceived facilitators and barriers to healthy diet in adults with type 2 diabetes. And then the second part is to share experiences in the development and validation of food literacy questionnaire. And the third part, I'll also share the experiences in a proof of concept randomized control trial in which we developed and implemented a behavior change intervention. So in the first part, which is the qualitative study, we initially planned to conduct a focus group discussion to collect data from participants in the area in which we intended to conduct the study. But because of the COVID pandemic, we converted the study into a telephone interview. Now, that was the first part of the changes that happened during this process. There were different players in the whole process. The first one is AMREF, African Medical Research Foundation, Ethics and Scientific Research Committee, and there are many things that actually guided us during that process with the interaction with AMREF. Then there's NACOSTI, which is the National Committee for Science and Technological Innovation in Kenya, which provides a research permit. And so these two bodies play a very important role in trying to contextualize the interventions. And then we are working in a legislative region in Kenya called Nakuru County. And so all these three players had a role in for us to try and contextualize the interventions and the studies that we conducted. Now, some things that we did not expect. First of all, nobody ever expected that COVID was going to change things. And the effect of COVID is that we had to reschedule many of our regional plans in our calendars. And the interaction with the ethical body and the research permits organizations in Kenya modified our protocols and improved them and made them much more applicable within the ground. And of course, the partnership between the university where I work, we were working with in Kenya, Jomo Kenyatta University of Agriculture and Technology, built a partnership in research. And of course, the changes from focus group discussions to telephone interviews and the changes that were brought about by COVID reduced the cost of this study. And so this picture here shows a meeting that I had with some Kenyan and Tanzanian colleagues here in Leuven in 2019 as we were planning for the focus group discussions. But of course, things changed. And here what we are trying is to test a translation from English to Kiswahili of the original focus group discussion. However, this was useful in the next phase of the telephone interviews because we modified the telephone interviews to the focus group discussion guides into telephone interviews and administered it in the next phase of our study. So there are circumstances that we faced during this particular study. One, some of the participants were not reachable. Reachable in what sense? Some actually hung up our calls, others did not take the calls, and poor connectivity in some parts of the country limited reaching the participants. The second circumstance was suspicion. In Kenya, we use mobile telephone banking. I'm sure most of you could have heard about the M-Pesa, which is quite a technological advancement, and we pride ourselves about it. So there are people who use telephone calls to scam or con people of their money. And so when people receive calls from people that they don't know, the first thing is a red flag is raised in their heads, and therefore they might be a bit unreceptive. The second one is suspicion, and this suspicion came from bosses. Interestingly, I will, for example, make a call to a participant who is a lady, but the husband is on the background and ask who is that calling. And so this suspicion is another circumstance that we did not expect. So what did we do in a way to adjust ourselves with this circumstance? The first one, we used community mobilizers. And who are community mobilizers? These are people who are known to the participants that were involved in the study. And we engaged with the community mobilizers right from the beginning, because in this study, we conducted it amongst participants in 6 hospitals in Nakuru County. And the community mobilizers were most of the time the clinicians or the records officers who are known to these people, and therefore they will introduce us to them either by telephone call, and most of them it was by telephone call because by then we had COVID restrictions that restricted movement in Kenya. The second approach was we use multilingual text messages, specifically using Kiswahili and English, sending a text message first of all to the participant and introducing ourselves and letting them know that we're going to call you at a certain time during the day so that they can be able to expect, and that will help us reduce the suspicion that was I talked about earlier on. Then seeking for alternative telephone numbers, Kenyans most of the time have more than one telephone number because of the different networks. And as I mentioned earlier on, there are places where connectivity is poor. So the different networks, we have Safaricom and we have Airtel that provides network services. So at times someone has a Safaricom number and has a telephone number or an Airtel number, which then enables them to be available at any time of at any time of the day. Sorry for that. Then the third one was repeating calls at different times of the day. Because most of the time you call someone, maybe someone is working and they cannot be able to take the call. So at times they might tell you, can you please call me in the evening? And some of the calls actually extended into 9 in the night. So in the second study, which was a development and validation of the food literacy questionnaire, of course, AMREF and NACOSTI were the standard bodies that we are dealing with, and they help in ethical approval and, of course, getting research permits to work in Kenya. Here, the second part, the other players that came into the picture that were not in the first study is we did this work in a different county that is neighboring Nairobi, and we also worked within the Seventh-day Adventist Church, also in Nairobi. Experiences from the previous study, like for example, making telephone calls and making consultation, and then inclusion of the community mobilizer, who was a member of the SDA church, helped us quite a lot in trying to understand the circumstances. And then, of course, amendment of the protocol to include transport reimbursement, which was very important because our expectation was going to collect the data on the day that participants go to church, but we learned something different that I'm going to share in a little while. And what was the objective of doing all these things? To ensure that we have supportive participants, because this study required that a participant is given a questionnaire to go and answer, then come back again, and then you give them another questionnaire and another questionnaire. So there are 3 cycles of giving and receiving questionnaire, and at times they needed to travel to where we are to return the questionnaires, and there we needed the transport reimbursement, and we also needed their support. Then we also needed referrals, because some of the participants may not have come to church on the days that you are there, and therefore referral was very important. And of course, the main objective was to try and reduce the attrition during the study. And so, what were the circumstances and actions that we took during this study? One, we needed a church board approval, and here we used the community mobilizers, and lucky enough, the community mobilizer was one of a colleague that was working within Jomo Kenyatta University. Then there was prohibition of non-worship activities before sunset, as it is in the Seventh-day Adventist Church. The activities that are not allowed during between sunset and sunrise and sunset. Sorry, sunset the previous day on Friday until sunset on Friday. So that means that the whole of the more than 24 hours, some activities were prohibited. Like, for example, we wouldn't issue money, transport reimbursement. We wouldn't conduct the interviews, issue the questionnaires. And the number of participants, by extension, therefore, was affected. So we rescheduled the issuance of questionnaires and dates for data collection. Then the researchers' acceptability was an issue, because many of the participants would be much more comfortable with people who are in the same church. And so we recruited some of the enumerators who are from the church, the SDA church. And enumerators compliant to church code of conduct, including dressing. Like, for example, the church does not allow people to go to church with trousers, and therefore we had to modify that through training and sensitization of the enumerators. And so in the third study, sorry, the slide is a bit muddled up than I expected. There are changes that actually happen, and things actually change on the ground, which is very true. Once again, the same players, AMREF, NACOSTI, come into play. And again, we are in Nakuru County this time around. This is the proof of concept study in which we wanted to determine whether we can be able to optimize glycemic control amongst people with type 2 diabetes in Nakuru County. There are expected circumstances, and the expected circumstances, one, of course, the good working relationship that we have developed with the county, And then the second one are the issues that I've discussed earlier on relating to mobile phones, network suspicion, but the unexpected circumstance, of course, the process of revision of the protocols so that they can be amenable to the ground and the requirements of AMREF ESRC improve the quality and applicability of our protocol. Now, on the flip side of the whole process, the procurement process of different items that were required for this study at Jomo Kenyatta University of Agriculture and Technology were affected by a national procurement and disposal act that was implemented in 2016. This had a big delay in some of the processes because it included a step-by-step approach that at times takes longer than it is expected. And this had an implication on our calendar and timelines. Here I share some of the things that we did. Lucky enough, through the funding of BLIR, we have a car for the project that we are running at Jomo Kenyatta University. And so here we were visiting the hospital during the study to collect some information from some of our community mobilizers who were records officer. And the lady on the far left is my supervisor, Dr. Chalo. Now, one funny thing is that as you see, this car is labeled with a BLIR was sticker. But this BLIR was sticker at some point was confused because there is some little stigma still relating to the HIV virus. So when it was seen, some participants in some other study that my colleague is running read as virus, because if you see the V's are darkened, so somebody can easily find out the word virus in this, and there was some little hesitancy that was created. So at times, some of these little things need to be taken into consideration in implementing studies in certain settings. So during the fieldwork experiences, you will expect that we'll have a lab to ourselves and collect data, but here we are collecting blood samples from a tent in a hospital. And we did some of the interviews on the beautiful lawns, as you can see, very beautiful and sunny. And then we had to do some anthropometric measurements on the waiting base because there wasn't enough space in the facilities. And these are some of the circumstances that we need to contend to, but ensuring that the quality of work and the quality of data that is collected was sustained. The same here, we used tablets, electronic questionnaires to collect data in the two facilities. One was called Molo and the other one was called Bahati, and we used the body composition analysis still under the tent to collect data for our work. In this slide, I will share some experiences because we are using mHealth, where we used to send text messages to the participants relating to food literacy. Now, in the first set where we have, it is in Kiswahili, this was a multilingual intervention where we initially asked the participants whether they'll be happy to use which language they'll be happy to get text messages for. And the first one is in Swahili. For purpose of confidentiality, I covered the numbers and their names in this presentation. The first one, the status would, there will be three possibilities. One, the participants will read the message, will receive the message and read the message. Here, we will just proceed without necessarily having to reach the participants. And the system that we are using, which was a commercial text messaging platform, will give us this feedback immediately within 5 seconds after sending the text messages. The second possibility, the message will be sent, will indicate as sent and be highlighted as blue. This means that the message was sent, but it has not been read by the participants. So what we will do in this case is to either call the participants, and if we call the participants and we are not able to reach them, then we will use the community mobilizers to try and reach them in using alternative means. Now, the third possibility is when it was blacklisted. Now, there are commercial text messages that are sent to mobile providers, by mobile providers in Kenya, and therefore someone can actually block all those messages so that they don't receive them using a code that is provided by the mobile provider. So what we will do in this case, we will call the participants and give them instructions on how to whitelist the text messages so that they can be able to continue receiving the text messages. So this is basically trying to understand and improve the implementation outcomes that we expected in our study. So in the third part of my presentation, which is the last part of this of my presentation, I will try to link different frameworks that are used in designing, implementing, and evaluating interventions to the experiences that we shared and what we did prior to this as we did our planning for this intervention. Once again, this slide has been modified because of the format of my presentation. Basically, the title is Behavior Change Wheel, which is the first intervention. And this is the intervention, this is the model that we used in designing and implementing our study. So in this, on the left side is a wheel that has green, then some red and shades of red. And then we have gray on the outer part. This wheel is used in diagnosing and finding intervention options for any behavior change that is being addressed. So what we did here is in the first part, which is the behavior diagnosis, it is known from this behavior change wheel model that capability and motivation capability and opportunity influences the motivation of an individual to change behavior. And therefore, this part helps in understanding the behavior and diagnosing the behavior as specifically as possible, so that once you are targeting a certain behavior, you have had an in-depth analysis of the circumstances to arrive at a certain behavior, and therefore you can be able to target the intervention to a specific component of behavior. So what did we do to try and to diagnose the problem accurately? First of all, we conducted a systematic review, trying to see how determining clinical and patient-centered implementation outcomes in low and middle-income countries, looking at it in the broader perspective. Then we conducted a qualitative study that I've just discussed about, and this qualitative study gave us information on different aspects of behavior change that the participants will need support in. And then we also did field visits and objective engagement with stakeholders, just like I've shared in the pictures that I've shared earlier on. So this behavior change wheel model prescribes 3 stages and 8 steps in the implementation process. So in defining the problem, which is a very important aspect of the implementation process, specifically the researchers need to identify the specific behavior, and then they specify the location and behavior and where the behavior occurs, and then specify the individual or group or population. This is a very important step because it helps in contextualizing and also bringing in the settings of the study. And then in each of the 3 stages, it is recommended that the APIS criteria is used. The APIS criteria is basically an acronym for affordability, practicality, effectiveness, acceptability, safety, and equity. Now, let me give you an example of why, for example, we chose the mobile text message in our study, in our proof of concept study. It is affordable, meaning that because many people in Kenya, nearly 97% of the Kenyans have mobile phones, it's practical and it's easily accessible by many people. It's effective in the settings where we are going to work from. Then, of course, there is the acceptability and there are no side effects. It is safe and it is equitable, meaning that everybody can be able to easily reach the intervention. And so that informed our choice of the mode of delivery, which was using text messages for that population. And why not, for example, mobile applications? Because mobile applications require some skills that the population of the people which are elderly cannot be able to reach. So in the second model, which is commonly used, the Medical Research Council, it prescribes different components for during the planning, implementation, and evaluation of complex interventions. So the first part is the development of the intervention or identification of the intervention, followed by feasibility, evaluation, and implementation. But in each of these different steps, there are core elements that help in trying to contextualize and also look at the settings of where the intervention is going to be conducted. The first one is, of course, consider the context, then engage the stakeholders, then identify key uncertainties and refining the intervention. And this helps in each of these steps to ensure that the context and settings are considered in any intervention. And then finally, the intervention mapping framework also applies, context and settings is extremely important in the intervention mapping framework, which is composed of 6 steps. In the first step, there is need to conduct needs assessment, and the needs assessment helps to understand what actually the problem is, so that the focus is actually on the actual problem, not the imagined problem. Then describe the context, which also includes the population, settings, and the community. And in the second step, there's also selection of determinants in relation to the environmental circumstances and outcomes, then constructing the matrices that are relevant to the objectives that have been selected. In the third step, there is also a component that helps in ensuring that there are modification of what is required to the change methods. And and in the fourth and the fifth step, there are always also components that focus on trying to contextualize the interventions to the settings. And so in my conclusion, selection and rigorous application of all steps of interventions or intervention frameworks or models increases chances of successful implementation. And secondly, there is need for a clear understanding of the unique research settings and contexts, and this helps in ensuring that the implementation achieves what it's set to achieve. Without the collaboration of all these players in my PhD work, it would have been difficult to achieve the outcomes that we intended to achieve. And these are my contacts. Thank you very much for listening. I'm sorry the slides were a bit muddled up than that I expected, but thank you very much, and I'm open for questions. Back to you, Prof.
Thank you so much, Moses. And indeed, it's possible with the Toledo platform that the layout is not optimal. And I explained before that many people prepare beautiful slides with some animations inserted, and then you present it and it's a mess. So this is not your responsibility. It's just because of the platform. So don't worry about that. The floor is open for questions. And I see, Zoe, perhaps you may read out your message to Moses.
Hi, can you hear me?
Yeah. Yes.
So no,
yes,
it was
I
just to
hear
say thank you for your presentation. It was really interesting to learn from your experiences and to see how you dealt with these challenges, especially with the recruitment in your qualitative study. It's really cool to see how how your research led to such a holistic picture. So it wasn't really a question; it's more like a compliment.
Yeah.
Thank you very much. I appreciate it.
Yeah, and I fully agree with you, Zoe. For me, it was a true eye-opener. We have our Western view on doing research and what is needed, but congratulations on the level of creativity you showed to actually realize your data collection, and on top of that in COVID time. So many challenges, and I think for us, I realize now that we are very culturally trained in an inappropriate cultural way, because we should learn how things are in different parts of the world as well. So I think that should be something for our educational programs as well.
Yeah, it's true. Thank you.
There's another comment or question.
I have a question yes? Regarding the intervention to send SMS messages instead of using mobile application or using smartphone. Is it just due to the smartphone penetration or the level of literacy to use such applications? What do you think of this?
Thank you very much. Unfortunately, I wasn't able to get your name. If I can answer, Prof.
This is Ahmed Zaid. Yeah.
Yes, Ahmed Zaid. Thank you very much. As I mentioned, we conducted a qualitative study that has been published recently in online, and what our findings were that text messages are effective in optimizing glycemic control in low and middle income countries. The only limitation is that text messages may not be at times acceptable to some populations. Now, the reason as why we selected text messages specifically is because the population that we were dealing with, first of all, coming from the qualitative study, were much more comfortable with using text messages because many were not accessible to get the smartphones. Most of them have basic phones. And of course, the technological aspect of the ability to maneuver around an application that requires a little bit of a higher skill sets in technology.
Mm-hmm. Sure.
Yes.
But from the other aspect, it's I think there is also other limitation in SMS, which is the personalization, because you can't personalize the SMS that reach everyone if you don't have a tool for data collection from them based on real life. But it's understandable that the SMS it's much more accessible. Yeah,
it is accessible, and there is also the possibility of personalizing the message. From the experience that we had, first of all, from literature, it shows that the more you engage the participants, the more the treatment outcomes are reached, coming from the systematic review that we conducted. But on the other side, from our experience of using a mobile platform, it is possible actually to personalize the message to the specific needs of the participants, only that it's a bit more laborious, but it's something that is actually possible using like using the platform that you're using. Because there was the option of sending group messages, there was the option of sending individual messages to the participants, and that is also very possible.
Sounds interesting. Thanks for
In
the
fact, you can actually check the platform. It's called Advanta Africa. I'm not sure that it's available to the rest of the world, but I know it's used among its many countries in Africa.
Mm-hmm.
Yeah.
Thank you, Moses.
Welcome, most welcome, man.
As probably you mentioned, it's labor intense if you have to adapt the text messages. But if I saw the picture on how you have to collect your data real life, I can also imagine that people have to travel far to go to a health clinic. So that the text message is probably then the most time efficient way to reach people.
Yes, true, Prof.
Yeah.
Very true. Yeah.
And of course, it's also true that you only reach those who have a mobile phone and are able to use it. And perhaps there's a future for you as well to reach out to people without connection. It's
very true. There are many options that are available according to literature, and also trying to be a bit practical in those settings.
Okay. Are there any other questions? And I'm sure you can contact Moses directly if he's in Leuven at the moment. So if you want to have a chat or learn more about doing research in Kenya, I'm sure you will be open to have a coffee together.
Yeah, I'll be glad to share coffee with anyone.
Okay, good luck with your work, Moses, and thank you for a very interesting presentation. I think it was an eye-opener for many of us. Good luck with the remainder of your PhD. Have a nice day, all of you.
It's my pleasure. Have a good day. Thanks, Prof.